Oh, thank you very much. I enjoy it, so don't worry. This is the Queen's Castle in the city center of Copenhagen. So disclosures haven't changed, unfortunately, during the day. So I think when moving from lobectomy to segmentectomies, when moving from open surgery to VATS lobectomy, my anatomical skills got a lot better. I needed better anatomical skills to do VATS lobectomy than I needed to do open lobectomy. Because I needed to know exactly what is behind this structure when you do VATS. In open, you're not that dependent on that knowledge because you can deal with it as it comes. And this goes for coming from lobectomy to segmentectomy. It challenges your anatomical knowledge even more, because if there are variations at the lobectomy level, there are a lot more variations on the segmental level. And so a very good anatomical knowledge and perception of where the segments are is crucial for doing segmentectomies, I think, and what makes this a really exciting operation as well, I must say. So Swanson published this paper a couple of years ago in the Annals of Thoracic Surgery, and I like this title so much. Is this the future of surgery for lung cancer, a VATS segmentectomy? I do believe it is going to be an important part of our armamentarium in the future, or in the present maybe as well. This is a very good operation, but there are some limitations. This is one of the very cited Japanese studies. It's a propensity score match study with sub 2 centimeter lesions, showing that local recurrence and overall survival is equal, maybe even better in the VATS segmentectomy group compared to the VATS lobectomy group. And Okada and his group has made some really nice papers. And also this paper from the same group, where they have measured the FEU1 after 6 months, and they could discriminate between wedge, segments, and lobectomy, and there was a significant difference in the post-op lung function between a segmentectomy and the lobectomy group, which is why we will do segmentectomies, of course. But again, we've been talking about evidence all morning, and these are retrospective studies on selected patients that we try to put back into the basket again. But we have divided them once, and making a propensity score matching might correct for some of these things, but not everything. So the only randomized study we have so far is this old study from Ginsberg, we all know very well, from 1995. And although this was up to 3 centimeter tumors and more than half, I think it was a wedge resection and not a proper anatomical segmentectomy, it still showed a higher local recurrence and a better survival for the lobectomy group. The CLGB trial, which was started almost 8 years ago now, has not finished yet. Inclusion's very slow. The Americans are very slow in recruiting for this study. And I've heard that, unfortunately, you can choose between a segmentectomy and wedge, and unfortunately most of the included patients are wedge resections. So I don't think this study is going to bring us any further, unfortunately. We've been waiting so many years for this study. There's another study going on in Japan, the JCOC study, and what I've heard is that they've stopped recruiting now, and they have started data analyzing. So I hope we'll get some data from this study very soon. But they have the right study, I think. They randomized between segmentectomy and lobectomy. So wedge is not an option, and it's sub 2 centimeters tumors. You can choose either, they stratify for either VATS or open. So I think this is going to be the first study that will bring us evidence and will guide us where we have to go in the future. So I think, as I as I read the literature, I still think lobectomy is the gold standard for a patient with no comorbidity and a normal lung function. If I was that patient, I would prefer to have a lobectomy. And we know we can do a VATS lobectomy with very low morbidity and low mortality. It's a safe operation, and we know the survival is good. So I think it's hard to argue in these patients to do a segmentectomy, in my mind. I know a lot of centers around the world are doing segmentectomy for these patients, but I don't think we have the evidence to do it. So be careful. But it's another thing with patients with compromised lung function. I think patient with compromised lung function, a segmentectomy is the absolute best operation you can get because you get access to the hilar lymph nodes. You can do a wedge resection in a very peripheral tumor, but you will not get the same access to the lymph nodes as you will in a segmentectomy. So it's a good cancer operation for this group. Synchronous lung cancers, we see more and more synchronous lung cancers. And with CT, lung cancer CT screening, we see the tumors very early, and sometimes we see several. And some of our patients will experience to have multiple resections for lung cancer. And in these patients, segmentectomy is really a good option. I use segmentectomies a lot for central metastases. So we used to do a lobectomy for 1 centimeter central tumor, which is, you feel bad about it. Even though the patient has a normal lung function, it's not ideal. I prefer to do segmentectomies in these patients. I think the alternative is an open procedure where you do a laser inoculation or even electrocoagulation. But personally, I don't like that kind of cancer operation because you have no resection margin, and I always have the feeling that I'll leave behind tumor cells. So I prefer to do, in these patients, I prefer to do a segmentectomy. And for most of these, I will apply atypical segmentectomies to save as much lung tissue as possible, and patients with severe comorbidity. So I think, this is still quite a large proportion of our patients. So it's definitely indicated to take up a segmentectomy program. So we use the same anterior approach as you know from lobectomy. It's exactly the same approach I apply for the segments. I did a publication in the Annals of Cardiothoracic Surgery where there's a video of lingular-sparing lobectomy. If someone's interested, you can see it. It's free on the internet. I'm not going to spend time on it now. Just show you that the basic principles. You see here the vein very clearly, the lingular vein and the vein for the remaining segments. Sometimes you see actually 5 branches. So there's one for each segment. So 4 and 5 is for the lingular. So that's the vein. Then after that, I turn to the superior trunk, exactly the same way as I do in an upper lobectomy. And then dissecting along the bronchus. And this is a little more tricky because you have to push the vein to the side, and then you have to move your dissection one step further into the parenchyma to see the division of the bronchus. And once having visualized the bronchus, I put the stapler in, I clamp it, and then I ventilate. And if it's all right, you can continue without any other maneuvers to resect the bronchus. And this is an A2 artery. And then at the end, checking. I usually don't open the fissure to the lingular because I don't want to get the lingular to rotate. So I don't want it to be too loose. So I try to keep the fissure in. But you need just to be sure that there is a lingular artery and that there is. That's the lingular artery. Yeah. Okay. We continue here. And then dividing the fissure, that's the posterior part of the fissure, and then inflating, you see very nicely, in this case, inflation of the lingular segment, and then you can resect along the borders, and then at the end checking that you have an artery, a vein, and the bronchus for the lingular segment. I'm going to show you a couple of video clips. This was a typical segmentectomies. So the typical segmentectomies are the lingular sparing, lingular, segment 6 sparing, or basilar segmentectomies. And this is one of the atypical segmentectomies. It's an A2 or posterior segment in the right upper lobe. There's a central metastasis, fibrosarcoma, normal lung function. Even though the patient has a normal lung function, I don't want to remove the entire upper lobe. So to begin with, I open the posterior fissure after having localized the tumor, of course. But you need to open the posterior fissure to get access to the vessels. So here you see the A2. These are small branches, so I think hemlock and ligature is enough for these small branches. But I do not solely divide with the ligature, even though it is FDA approved. I don't trust it 100%. I sleep better with a clip, and then since it is the artery, I put a clip distal as well. So I think part of this is you need to open the fissure in cases like this. So if you have a very thick fissure, of course there's a risk of air leak there, but I don't know how to manage this in a fissureless technique. I think it's the only way I can do it is to open up the fissure and get an idea of the anatomy. So that's the artery, and then we come to the vein. Usually the vessels and the bronchus are next to one another for the segments. So, and again, putting on a clip on the vein, dividing with the ligature. So I think the part of a segmentectomy where you divide the hilar structures is pretty much the same as when you do a vasculobectomy. You just take it one step further. So that's usually not a big deal, really. You have to remove the lymph nodes to get an idea. So I did a double sealing there because I didn't want to put a clips distal. Then turning to the bronchus, and again, it's important to having divided the bronchus so that you see clearly. I think the easy thing if you see clearly where the branches are going, so you know exactly what you're doing. So this is, now you'll see that I'm clamping. I'm using purple for the segmental, a purple cartilage for the segmental bronchus. And now you see the ventilation. This patient has a normal lung function, so you will see it very clearly. In emphysematous patients, you have like a split second to see it, and then there's crossing over the borders of the segments. So there you see very clear segment 1 and segment 3, and a deflated segment 2. So the next step, I think, is sometimes the most difficult in segmentectomies is handling the intersegmental planes, because there's not so much space once you have inflated the lung. And in this case, it's a metastasis, so I want to have at least 1 centimeter of resection margin to the metastases. That's why you can palpate while you put in the stapler. Some surgeons put a marking with the electrocoagulation to after inflation. I usually just remember where it is. I think if you're not entirely anatomical with this stapling, it probably doesn't matter that much. But of course, that's another discussion. I know Dartevell, he's a proponent of the peeling technique. He believes that with the stapling, you kind of fold the lung and you get a worse lung function postoperatively. He's probably right, I think, but you avoid the air leak that you definitely will get if you do the peeling. So there you go, there's the segment with a really nice resection margin in a very central tumor. Having tried to do a very deep wedge, there was a high risk of prolonged air leak, and probably I would have gotten very narrow resection margin. And so doing the air test at the end, it looks really nice, and I think in patients like this, we have these patients with metastases, even though we have no evidence, as Tom Treasure said this morning, we have these patients coming back for repeated surgery, and I think it's crucial to be as lung sparing as possible, because you never know when they come back. And if this was not lung cancer, but if it is lung cancer, of course you should do a full lymph node dissection, removing all the lymph nodes along the bronchus intermedius, subcarinal area, station 8 and 9, the hilar lymph nodes. This goes with segmentectomy as with lobectomy, I think. And despite the patient has a very compromised lung function, I think it's safe to remove the lymph nodes carefully, all the lymph nodes, as long as you don't injure the recurrent nerve, which is a really bad idea in patients with a poor lung function. And there, the subcarinal area. So you see the subclavian artery. And I always leave this area because that's where the recurrent is swinging around the subclavian arteries. You should be careful in that area. Then you'll make if you go for the lymph nodes in that top area, you'll have a recurrent nerve paralysis. Yeah, that's all I had to say for now. I'll encourage everyone to do some segmentectomies. It's a nice sedation. Yeah.